Hello and welcome to the topic psoriasis in the dermatology module. By the end of this topic, you should be able to define psoriasis, explain the etiology and pathophysiology of psoriasis, describe the clinical features of psoriasis, list the differential diagnosis of psoriasis, outline the investigations to diagnose this condition, discuss the principles of management, and discuss the complications of psoriasis if not well controlled. Now let's start by understanding the definition of psoriasis. Before doing that, let's learn about the etymology of the word. Psoriasis comes from the Greek word psora, which means itch, and iasis, which indicates an action or condition. Medically, psoriasis is a complex, chronic inflammatory skin disease characterized by erythematous, clearly defined red and scaly plaques. This is due to hyperproliferation of keratinocytes and inflammatory cell infiltration. Now let's look at the pathophysiology and causes of psoriasis. Psoriasis is multifactorial. The exact etiology is unknown, but there are several factors that have been suggested, which are genetics, as psoriasis has been linked to a number of genes including HLA-CW6 and those coding for IL-23R, IL-12B and tumor necrosis factor alpha. There's a strong family history. As for immunological factors, as shown by genetic studies, psoriasis also reappears after cessation of systemic corticosteroids and is aggravated by the use of antimalarials, lithium, and beta-blocker drugs, and its lesions are associated with increased activity of T cells in underlying skin. In the case of guttate psoriasis, which is often observed following an upper respiratory tract infection, viral infection and immunization have also been linked to flares of psoriasis. There are also several precipitating factors such as smoking, obesity, alcohol, menopause, puberty, emotional stress, and sunlight, to name a few. Let's quickly dive into the pathophysiology. Remember, psoriasis is a hyperproliferative disorder involving a complex cascade of inflammatory mediators in the dermis. As a result, there would be migration of T cells, dendritic cells, and macrophages to the epidermis, causing the stimulation of keratinocyte proliferation. Thus, there is an overabundance of keratinocytes, and this will then cause epidermal thickening and rapid turnover of the stratum corneum. The epidermal thickening leads to the formation of papules and plaque, while the rapid turnover of the stratum corneum leads to silver scale that you see on the surface of psoriasiform lesions. In addition to that, the migration of T cells, dendritic cells, and macrophages to the epidermis also causes regional release of pro-inflammatory cytokines, leading to the development of neutrophil-packed vesicles, causing the pustules appearance. Lastly, the sharply demarcated erythematous plaques appear as a result of the stimulation of the keratinocyte proliferation and the regional release of pro-inflammatory cytokines. Moving on to the symptoms of psoriasis, on history taking, some of the things to look out for are complaints of worsening of a long-term erythematous scaly area, sudden onset of many small areas of scaly redness, recent streptococcal throat infection, viral infection, immunization, use of anti-malarial drug or trauma, family history of similar skin condition, pain especially in erythrodermic psoriasis, pruritus especially in eruptive guttate psoriasis, itchiness which is often accompanied by excoriation, afebrile except in pustular or erythrodermic psoriasis, dystrophic nails, long-term rash with recent presentation of joint pain without any visible skin findings. Do bear in mind that the skin almost always is affected before the eyes. The most common ocular symptoms are redness and tearing due to conjunctivitis and blepharitis, and the non-ocular symptoms are related to rash and psoriatic arthritis. The rash can become uncomfortable or even painful, and psoriatic arthritis can cause stiffness, pain, throbbing, swelling, or tenderness of the joints. Before we move on to the signs of psoriasis on physical examination, it is important to know that psoriasis can be classified into different types. Here we will classify it according to the International Psoriasis Council. First, we have the plaque psoriasis. You'll be able to see raised inflamed plaque lesions with a superficial silvery white scaly eruption. The scale may be scraped away to reveal inflamed and sometimes friable skin beneath, and the picture here shows a plaque psoriasis on the knee. Next, there is guttate psoriasis. They are usually widespread, erythematous, fine, scaly papules which look like a water drop appearance as seen on this picture here. The lesions often erupt after an upper respiratory tract infection. Thirdly, there's pustular psoriasis, and here you will see acute generalized pustular psoriasis, which is usually rare, but severe and urgent, and there may also be palmoplantar pustulosis, which is the chronic involvement of the hands and feet. Then there is erythrodermic psoriasis. There is generalized erythema with fine scaling seen, and it is often associated with pain, irritation, and sometimes severe itching. Moving on, let's discuss psoriatic arthritis. This is unique, and what I mean by this is that in addition to the skin lesions, there's also joint involvement, which may cause inflammatory damage and deformity. Do take note that most people with nail psoriasis have psoriatic arthritis. Lastly, there is keratoderma blenohagicum, which is under the category of reactive arthritis, and this is a reactive immune disorder characterized by psoriaciform plaques, urethritis and cervicitis, conjunctivitis, and arthritis. You will see circular, scaly, scalloped, edged, hyperkeratotic psoriaciform plaques and papules, which is sometimes painful and pustular. The findings on physical exam will depend on the type of psoriasis present as explained on the previous slides. Generally, you would expect to see symmetrical distribution, red scaly erythematous macules, papules and plaques with well-defined edges. The scale is typically silvery white except in skin folds where the plaques often appear shiny with a moist peeling surface. Typically, the macules are seen first, and these progress to macular papules and ultimately well-demarcated non-coherent silver plaques overlying a glossy homogeneous erythema. Itch may also be present as described previously, which leads to scratching and lichenification, and this is characterized by thickened leathery skin and increased skin marking. Painful skin cracks or fissures may also be seen. Resolving patches of psoriasis often leave brown-colored marks that are generally fading over periods of months. The area of skin involved varies with the form of psoriasis. The most common sites are the scalp, elbows, and knees, but essentially any part of the skin can be involved. There are a few differential diagnoses that can be considered when you think of psoriasis, and firstly being systemic lupus erythematosus. Subacute SLE may have clinical features of psoriasis, but plaques are usually less scaly and non-lamellar. Secondly, you should consider pityriasis rosacea. Here, the lesions may show features of gutted psoriasis but are in a characteristic Christmas tree-shaped distribution. Another thing to know is that pityriasis rosacea usually subsides within 8 weeks. Next, there's seborrheic dermatitis. These are scaly eruptions and which are limited to the scalp, ears, eyebrows, paranasal region and chest. The scales are usually fine and non-lamellar. Mycosis fungoides. Here the patient will complain of severe itchiness and lesions are less scaly. There's no involvement of the nails or joints, and it is usually not found on the scalp or ears either. Nappy dermatitis, which is a very obvious differentiating factor, is that the lesions are oozy, weepy, scaly, and only found in the nappy region. Moving on to onychomycosis, this only involves the nails. Eczema, the lesions are extremely itchy and they are mostly oozy, crusted with a lot of scratch marks. And lastly, you should also consider squamous cell cancer or actinic keratosis. Here the lesions are not as scaly, or in the case of actinic keratosis, fine-scaled may be present. Squamous cell cancer is limited to a few lesions. And remember, this list is not exhaustive. There are many more differential diagnoses to consider. The diagnosis of psoriasis is made clinically. There is often no need to order any investigations. However, a skin biopsy can be ordered when the diagnosis is in doubt. But do remember that a biopsy does not always show classic pathological features. Usually in psoriasis, you would expect intraepidermal spongiform pustules and Monro neutrophilic microabscess within the stratum corneum. In addition to that, you may also see focal parakeratosis and epidermal acanthosis with dilated capillaries within dermal papillae. This slide here shows you an example of a skin biopsy taken from a plaque psoriasis lesion. Number 1 shows hyperkeratosis and parakeratosis. Number 2 shows you neutrophils in the epidermis. In number 3, you can see thinning of the epidermis overlying the dermal papillae. Number 4 basically shows the vessels close to the epidermis. And number 5 over here shows you the elongated red ridges. Lastly, let's discuss the ways to manage psoriasis. Firstly, we'll look at the non-pharmacological management, and this includes patient education where the diagnosis and appropriate ways to manage are explained to the patient. advising the patient to modify their lifestyle in order to minimize risk factors and to avoid known precipitating factors, as mentioned before, such as smoking cessation, reduction of alcohol intake, weight loss, avoidance of sun exposure, and management of stress. The main aim of therapy is to gain rapid control of the disease process, decrease the percentage of body surface involved, decrease the number of plaque lesions, and to achieve and maintain remission. Pharmacologically, the management can be looked at based on severity, which is mild, moderate to severe psoriasis. In the case of mild psoriasis, topical treatments are the mainstay of therapy. This includes creams, ointments, and lotions. For patients with limited psoriasis involvement, start with topical corticosteroids and/or topical vitamin D analogues. Emollients may be used by those averse to pharmacological options. Now let's look at moderate to severe psoriasis. The main options for this treatment are phototherapy, which includes narrowband UVB and PUVA. Narrowband UVB is currently the most commonly used phototherapy to treat psoriasis, and it carries a lower risk of skin cancer compared to UVA. PUVA is a combination treatment of oral methoxsalen and UVA and is effective in controlling psoriasis, particularly widespread disease. Conventional systemic therapy include methotrexate, acitretin, and cyclosporin. Biological agents such as etanercept, infliximab, and adalimumab also can be used, and some dermatologists may use biological agents in combination with other agents. The biological agents act at a cellular level and target particular steps in the immunological process. In addition to that, let's briefly go through the management of gutted psoriasis and erythrodermic or pustular psoriasis too. In the case of gutted psoriasis, the first-line treatment is phototherapy. The second and third-line treatment would be your oral systemic therapies. For erythrodermic pustular psoriasis, rapid and aggressive control is crucial. The initial treatment with cyclosporin for around 3 weeks is needed to manage the flare. Patients who are more stable can be started with a biological agent, and it is necessary to provide electrolyte monitoring and supportive care to all patients with erythrodermic psoriasis. Pustular psoriasis, on the other hand, can be treated with oral retinoid acitretin, which is the first line, or with a combination of acitretin and phototherapy. Once again, provide electrolyte monitoring and supportive care to all patients with extensive pustular psoriasis. Bear in mind that children, pregnant women, and immunosuppressed individuals should receive specialist care. Now let's summarize what we have covered so far. Psoriasis is a complex chronic inflammatory skin disease characterized by erythematous clearly defined red and scaly plaques. It is multifactorial, and psoriasis is proposed to be due to genetic, immunological factors and infections. Essentially, psoriasis is a hyperproliferative disorder involving a complex cascade of inflammatory mediators in the dermis, which eventually leads to overabundance of keratinocytes. Psoriasis can be classified into plaque psoriasis, gutted psoriasis, pustular, erythrodermic, psoriatic arthritis, and keratoderma blennohagicum. Clinical manifestations of psoriasis depends on the type of psoriasis seen. There are various differential diagnoses to consider when you think of psoriasis. Diagnostic-wise, psoriasis is mainly diagnosed clinically, but a skin biopsy can be done if the diagnosis is in doubt. And in terms of management, there are non-pharmacological and pharmacological treatment. As for non-pharmacological treatment, this includes patient education as well as lifestyle modifications. Pharmacological management depends on the severity of psoriasis. Mild or limited psoriasis is treated with topical corticosteroids and/or vitamin D analogues. Moderate to severe may require phototherapy, conventional systemic therapy, apremilast, and biological agents. We have come to the end of this topic. Thank you.